Chapter 14, Infection and HIV. Okay, so we're talking about HIV, the human immunodeficiency virus. So HIV is a retrovirus that causes immunosuppression. It's a ribonucleic acid, and the target cell is CD4 plus T cells. So if you remember, CD4 plus T cells are very important in our immune response. So please refer back to that chapter to refresh your memory. Without CD4 plus cells, we really can't maintain an immune response to normal pathogens that we encounter. Okay, so you can watch this video. I'm going to play it and you can fast forward if you'd like.
When HIV first enters the human bloodstream, the virus circulates throughout the body. The protective surface of HIV is studded with particular proteins called GP120, and inside is a capsid that contains the viral RNA and viral enzymes. Initially, the GP120 protein on the virus is only able to bind to a cell surface protein on the macrophage called the CD4 receptor. A second receptor protein, CCR5, must also be present on the macrophage for the virus to enter the cell by endocytosis. Viral RNA and enzymes are released into the cell's cytoplasm. Reverse transcriptase uses the viral RNA to synthesize first a strand of viral DNA and then the complementary DNA strand. The viral DNA then moves to the nucleus of the cell, where it integrates into the host cell's DNA. Transcription of the DNA within the nucleus now results in the production of viral RNA. This viral RNA can serve as the genome for new viruses and can be used as messenger RNA to produce viral proteins during translation by the ribosomes. Complete viruses are assembled and released from the cell via exocytosis, which causes little harm to the macrophage. HIV cycles through macrophages over a period of years and continues to multiply while doing little apparent damage to the body. Eventually, the gene that codes for the GP120 protein is altered by mutation. The altered GP120 protein changes its co-receptor allegiance and now binds to a different co-receptor, CXCR4, which is found on the surface of CD4 plus T cells. The same processes occur within the T cells, resulting in new virus particles. However, as these new viruses leave the T cell, they rupture the plasma membrane, which kills the cell. As these newly released viruses invade and destroy other T cells, the body's immune response is weakened, and this leads directly to the onset of AIDS.
Okay, so that video shows the complicated process, the complex process of HIV. So what I want you to take away from that video is that at the beginning, there is not a lot of destruction of our cells. At first, they're able to do its thing without really having an impact on our immune system. But over time, as the mutations become more and more apparent, that's when our immune system is going to take a dive, and that's when we start to see all of these opportunistic diseases come in, and that's when AIDS can, when that AIDS diagnosis can be made. All right, so let's look at some numbers here. So immune system problems start when the CD4 plus T cell counts drops less than 500. Okay, so when it drops less than 500, that's when we start to see clinical manifestations. Severe problems developed when that CD4 plus count goes lower than 200. Okay, so normally a healthy person has between 800 to 1200, so that should be kind of your reference. Okay, so 500 is when we start to see things. 200 is severe, is considered critical. All right, so HIV does not kill a person. That virus does not actually kill the person. It just makes their immune system very, 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 very weak and pretty much non-existent once these CD4 plus T cells become very, very critically low. Okay, so what these patients typically die from is that opportunistic disease that comes in, they die from that disease. Just so you know, HIV is no longer considered a death sentence. This is considered a chronic disease when managed. Okay, so how is HIV transmitted? So bodily fluids, blood, semen, vaginal secretions, breast milk. The most common mode of transmission is unprotected sex. Okay, so back in the 70s when HIV was very prevalent and new, and a lot of people didn't know about it, there were a lot of misconceptions that you could actually get the virus from sharing food and drinks, mosquito bites, kissing, touching, clothes, or using the same toilet and shower. But that is not how HIV is transmitted. Okay, so it is transmitted from the use of non-sterile syringes and tools, so needles, anything that should be sterilized after procedure. If it is not sterilized, you can pass along this virus. Okay, pregnancy, breastfeeding, blood transfusion. Again, blood transfusion, we have lots of really good screening nowadays, so that isn't as common. Organ transplant, same idea with the blood transfusion. And then, of course, as I mentioned, 80% of HIV is transmitted through unprotected sex. So unprotected sex is considered preventable. Of course, nurses, we're all about prevention. So you can kind of start thinking, okay, how do we prevent HIV? All right, timeline for untreated HIV. Okay, keyword is untreated. So patient becomes infected with the virus. So what is it going to look like? All right, so we're looking at the acute infection here. Okay, acute time period, that's considered the first 1 to 3 weeks after being exposed to the virus. Okay, and if you look here, HIV antibody test doesn't become positive until about 3 weeks to 3 months later. Okay, so they'll be infected, but we can't test for it quite yet. Okay, it doesn't mean that they can't pass it around. It just means that if the patient tests too soon, it might be negative, so that might be a false negative. All right, then look at this long period of time, months to years of asymptomatic infection. So at the beginning, they'll have some signs and symptoms, but those symptoms will go away and then they become asymptomatic. That is why this is very scary, because if patients don't get diagnosed early, then they can live a very long time, years, without knowing that they have the virus, not having any signs and symptoms, and they're able to pass it along to, multiple partners. Okay, so after several years have passed, this is when they're going to have symptoms again. And by that time, it's going to be advanced and their immune system is going to be very compromised. And then, again, this is if left untreated, it will eventually turn into AIDS, which is terminal. So we will find out what the definition of AIDS is in a moment. All right, so what are the signs and symptoms of having HIV? Okay, so here we just talked about the acute phase, the asymptomatic phase. They become symptomatic again, and then that will ultimately lead to AIDS. So here we are at the acute infection. Okay, this is just a couple of weeks at the beginning. So there are HIV-specific antibodies produced at this time. Patient can have fever, swollen lymph nodes, pharyngitis, which is sore throat, headache, malaise, nausea, diffuse rash. So if you notice these things, these are very common signs and symptoms. You could have the flu, you can have a really bad cold, you can have something else. So oftentimes if the patient comes to a clinic or a doctor's office, presents with these symptoms, the provider may not recognize that as a possible acute infection of HIV, especially if the patient doesn't look like your quote typical HIV patient, positive patient. There are some risk factors, if you see a patient come in and they're obviously maybe drug users, IV, if it's very apparent, then of course they might refer the patient to have an HIV test. But if it's just a regular quote regular person that you wouldn't think that, these patients can be often dismissed. So that is something that we as nurses can include in our history and physical. Is their sexual history, what's going on in their life, what kind of behaviors do they have? So if they are high risk, then we can definitely screen them for HIV. All right, so acute infection, they are highly infectious during this period. Then we enter that asymptomatic infection. So this again is the interval between they have the virus, but they had the virus, they had those symptoms at the beginning, but now they're asymptomatic. So the time between they had the infection at the beginning till the progression to AIDS is about 10 years. Okay, so during this asymptomatic infection, their CD4 count still remains higher than 500, because remember, 500 is the threshold. Once we hit that 500 marker and below, that's when we start to see those manifestations. Okay, so again, like I said, those high-risk behaviors may continue because they don't know any better. Then we come to this part, symptomatic infection. This is when their CD4 plus count is going to go lower than 200, and this is an advanced stage. Symptoms are going to become worse. Now they're going to have fever, night sweats, chronic diarrhea, recurrent headaches, and severe fatigue. So here are some things that can kind of manifest. Shingles, candidal infections, that's like thrush, oral, genital herpes, bacterial infections. All of these things that we normally don't see that often are going to become very common in HIV patients. So AIDS, what is the definition of AIDS? So we follow the CDC guidelines on what we consider AIDS. So AIDS is going to be a person who has HIV and an AIDS defining condition. Okay, so there's lots of different AIDS defining conditions in this box. This is all you need to know for this class. Okay, so that's one way to diagnose a patient, okay, having HIV and an AIDS defining condition, or they have a CD4 count less than 200. And if it's less than 200, then they don't necessarily need an AIDS defining condition to be diagnosed. Okay, so those are the two things. All right, so just be familiar with the names of these conditions, okay? So their immune system is severely compromised. So these patients are very high risk for infections, cancer, muscle wasting, and just some cognitive changes that comes along with that virus. As you can see in this picture, this is Kaposi sarcoma. This is a type of cancer, very, almost exclusively seen in AIDS patients. They're like these purplish black lesions on the skin, like a type of skin cancer. All right, so how is this diagnosed? How can we check to see if the patient has this virus? So most commonly, there's several different testing, and you can see the difference between this testing is how sensitive they are to detect it. So if you see here, these nucleic acid tests, the NAT testing, it's can usually detect the infection 10 to 33 days after exposure. These antigen antibody tests, 18 to 45 days, and then these HIV specific antibody tests, 23 to 90 days. So the takeaway from here is that there are different tests that can test for HIV. However, they have different sensitivity time periods. Okay, so we have to remember that. And then that time period where a patient may have been exposed to the time that whether they can actually be positive for the virus is called the window period. Okay, again, the window period is when they possibly have been exposed all the way up into the time where we can actually test for the virus. So, for example, a patient comes in and says, hey, I think I've been exposed to HIV. Can you test me? Sure. They do the test, but it comes out negative. Okay, that is not the end. They need to come back for retesting, at least probably up to a year, even 6 months to a year, just to make sure that it is a true negative result, because we know that this virus doesn't show up right away, and depending on the test, you can have a false negative. All right. Okay, so when the patient is positively diagnosed for the HIV, the way we're going to monitor the progression is the CD4 plus cell count, viral load, and then the white blood cell, red blood cell, and platelet level, because they are going to have pancytopenia, okay, as a result of this virus. So when we check to see, are they stable? Are they getting worse? These are the labs that we are going to monitor. All right, so let's talk about ART therapy, antiretroviral therapy. So these are all the antiviral meds used to treat HIV. Okay, so what you need to remember is that these medications are very potent, they're very strong, and they have side effects. So we already know they have side effects. We're going to anticipate them, we're going to educate the patient on them, and we need to monitor the patient for these side effects. Okay, so here we go. Anemia is very commonly associated with ART therapy, so we are going to expect it. Altered liver function, which means that's going to be part of the routine lab work that these patients will have. It's really important. Resistant tests can help determine if a patient is resistant to ART. So a patient can become resistant to these medications. There are lots of antiretroviral medications that we can experiment with, and I say experiment with meaning if a patient doesn't do well on some combination, then the provider can switch it up and try a different combination until we can find something that works for the patient that has the least amount of side effects for them. Then we can do assays. This is like genetic testing to even look deeper to see which medications would be more effective for a specific patient, and we refer to that as genotype assay and phenotype assay. This table is from your textbook. It lists the drug therapy for HIV. So you can see here all of these medications and their mechanism of action. You have the names in the third column. So you don't have to be super familiar with these names. Just we're going to refer to them as ART therapy as kind of like a whole, okay? So just to note here, there can be interactions with over-the-counter medications for these ART drugs. So that's part of the teaching for the patient. They shouldn't really be taking any over-the-counter medications until they clear it with a doctor. Okay, so again, avoid over-the-counter medications when patients are on ART therapy. Okay, so the goals of ART therapy is to decrease the viral load, to maintain their immune system, which is monitoring those CD4 counts. We want to prevent them from getting any of those opportunistic diseases that can possibly kill them. We want to delay disease progression. So we know this disease has a potential to become much, much worse. So we want to do our due diligence to try to stop that from happening. And then these patients are HIV positive, so we want to prevent them from passing it along to somebody else. Okay, so ART therapy, I'm right here, can significantly lower HIV progression, but it's very complex. Again, that ART therapy, very potent medications, has a lot of side effects, and it doesn't work for everyone, and it's very expensive. So often patients who have HIV have, a lot of reasons why they can't take it consistently. Maybe they're homeless, maybe they're on the street, maybe they don't have education, maybe it's too expensive, they don't have insurance. Maybe the side effects are, making it really hard to take them every day. So all of these things have to be taken into consideration. When to start this ART therapy? It should be started as soon as possible after diagnosis. As soon as possible after diagnosis. Patient readiness is the most important concern because they need to take these medications daily, routinely for the rest of their life. If they don't take them consistently, they can build a resistance to them. So that's why it's really important that they're ready, they understand, so that they can have the best possible outcome. So nurses can educate, provide support, including medication adherence counseling, like I said. All right, and again, just reiterating, adherence to drug regimens is critical in their health outcome because it will slow or prevent disease progression and those opportunistic diseases. It will prevent drug resistance. So an individualized approach is best. Not all patients are the same. Okay, they need to be monitored so that they can have the best combination of drug therapy that works for them. All right, so what kind of side effects are we talking about with the long-term use of ART therapy? Metabolic disorders, very, very common. Okay, so they may develop a set of metabolic disorders. These are common listed here. They can have kidney problems, cardiovascular problems, hyperlipidemia, insulin resistance, hyperglycemia, bone disease, lactic acidosis, and lipodystrophy. A lot of different things. So, for example, you have a patient that is experiencing this lipodystrophy. So what is it? here we have, it is going to be a redistribution of fat. Okay, so you can see in this picture a redistribution of fat in the abdomen, also in the upper back. You can't really see it in this picture, in the breast area. And then they have fat loss in the arms, legs, and face. Okay, so this is lipodystrophy. So say you have a patient who comes in and they're complaining of body changes or maybe some, other manifestations that we just talked about on the previous slide. So you can expect the provider to take a look at their medications and switch up their combination. These patients are going to be on more than one, and that's because we don't want resistance. Okay, it's a stronger force when you have multiple medications working in combination. So they're not going to tell the patient, hey, stop those medications or don't take, a lower dose or something like that. They're going to change the combination. That's what you can expect. All right, so again, this is just the same stuff over and over. We want to monitor for disease progression. We want to make sure their immune system is functioning adequately and manage their symptoms. Drug therapy, once they're diagnosed, we want to get them started on that ART therapy and make sure that we monitor them regularly. Our end goal is to avoid opportunistic infections because ultimately that is what will kill them. Manage symptoms, decrease complications. We don't want them to transmit that HIV, so there's going to be a lot of education, safe sex, stuff like that. The very first time they come in, we're going to teach them about HIV, the treatment, preventing transmission, improving health and family planning, because maybe these patients are going to want to have a baby, so we want to make sure that they do this with all the education and as safely as possible. So when you have an HIV patient, HIV positive patient, this is very common when you work in a clinic. There's often clinics just for HIV patients, and those are the only type of patients that they see. You don't want to make any assumptions about who may be at risk. Okay, so you see these pictures here. All of these people, have come out publicly saying that they are HIV positive. So does this fit the mold in your head of like, hey, yeah, she looks like she would be HIV positive, he, she, and so on. You don't want to assume. What you want to do is get a good history and physical when you talk to these patients. Take a look at their symptoms, ask questions, find out if they are high risk, and then go from there. So some questions are, have you received a blood transfusion before 1985? Do you share needles? Have you had these certain sexual experiences? And do you have a sexually transmitted infection or previously had one? Because that puts you at risk, higher risk for getting HIV. So those are the kind of questions you want to ask. That's how you kind of want to look at the situation. So health promotion, like I said, HIV is preventable. So we want to educate on how to prevent it. So you want to avoid or modify those risky behaviors. Okay, so if you want to have sexual intercourse with 15 people, okay, but let's find a safe way to do it if you must, right? You want to be culturally sensitive, provide language that's appropriate, age specific, because you can have teens, adolescents also doing these risky behaviors. So you want to make sure that you're speaking at a level that they'll understand. And then you want to be aware that these are sensitive topics, sexuality, drug use. So you need to be comfortable talking about that, and that takes practice. Okay, so we want to increase safer sexual practices, advise them not to do the drugs. We want to decrease perinatal transmission and decrease risk. So for example, needle sticks. Just like we were talking about hepatitis B and C, we can also get HIV through needle sticks. So we want to make sure we're taking all of those necessary safety precautions. All right, so per the CDC, testing is the only sure method to determine an HIV infection. Okay, similar to like cancer in a biopsy, only way to diagnose HIV is through testing. So CDC recommends universal voluntary testing as part of routine medical care. An estimated 14% of people who are living with HIV are not aware that they're even infected. Okay, so let's go back to this word voluntary. All right, so a provider cannot force you to get HIV testing. So I often use this example, I may have said it in lecture, when a patient comes in admitted to the hospital and they're a dialysis patient, they usually get a standard set of labs ordered for those patients, and included in that is an HIV test. So because having dialysis, you're dealing with blood products, they're at higher risk for having the virus, so it's routinely done to screen them when they're admitted to the hospital. However, it is still a voluntary test, so even though it's part of a standard order set, you still need to get a consent from the patient to actually have an HIV test. The exception for that would be if the patient is unable to make their own decisions. In that case, you would need to have the doctor kind of override that and, get two physicians to okay that. So remember, HIV testing is voluntary. Okay, now we're here at our last slide. So if HIV is left untreated, the patient will ultimately die. It may take several years for all of these things to manifest, but ultimately their immune system is going to be severely compromised. They are going to get an opportunistic disease, infection, and they will die. So we have to be aware of end-of-life care. Okay, so we already know about hospice and end-of-life care, so I'm not going to go over this. And then we have gerontologic considerations. So the number of older adults with HIV disease is increasing. Okay, the death rate from opportunistic infections is actually reduced because, we have lots of medical care. And then people over 60 are increasingly being infected. Why is that? Well, the older we get, the less likely we are to use some type of condom, barrier, because usually, when you get older, you're not thinking of pregnancy. So they think, well, I don't have to use anything, I'm not going to get pregnant. But actually, they still can get, a sexually transmitted infection. So that is why older adults with HIV disease is increasing. All right, so that concludes this chapter.